So first of all, thank you for having me. Happy to be here. I'm Ioannis Parodis. I'm a senior consultant rheumatologist at the Karolinska University Hospital and an associate professor of rheumatology at the Karolinska Institutet, also affiliated to the Örebro University. 15 years ago, we didn't even have approved targeted therapies for lupus. Now we have several options to choose among. We have belimumab, which was the first biological that received approval for treating SLE. This was back in 2011. More recently, anifrolumab received approval for treating SLE. For lupus nephritis specifically, we have now voclosporin that recently received approval. It is also a targeted therapy inhibiting calcineurin. That received approval for treating active lupus nephritis as an add-on therapy. This was also the case for belimumab recently. So now we have options for treating lupus and we have options for treating lupus nephritis. What we need to understand better is how to choose wisely among these options. And there is a knowledge gap. We need to understand better the mechanisms that lie under the clinical phenotypes, because we have now seen from different omics-based studies that molecular patterns do not go along with the clinical phenotypes. So we need to understand better the mechanisms, and maybe what I can foresee in the future is that we will more and more move towards a paradigm shift from the taxonomies that we have today, taxonomies and classifications of diseases based on certain clinical facets and certain labs, towards a molecular characterization of the diseases. We start more and more understanding which signatures we're dealing with in patients with SLE. Now it is important to remember that different autoimmune diseases share common mechanisms many times. So we can actually even borrow therapies from different autoimmune diseases and apply them to lupus. And we have been doing so in the past with the application of off-label biologicals. We have, for example, used rituximab off-label for many years and have seen good results in some settings. Rituximab did not make it in phase 3 clinical trials to show additional efficacy to standard of care therapy. But we have several examples from observational studies that rituximab works well in some cases of lupus. So what is important to remember is that one size does not fit all. So we do need to understand more about which patients could be suitable for which therapies. Now we start understanding more about the mechanisms underlying different autoimmune diseases, and more specifically, mechanisms underlying systemic lupus erythematosus. And we start also understanding which signatures can be reversed by inhibition or stimulation of specific targets, of specific genes. So based on this knowledge, I believe that we in the future will be able to direct targeted therapies better in a personalized manner. We know, for example, that patients with a high interferon signature will be more suitable for anifrolumab therapy than patients with a low interferon signature. And this kind of stratification, I think, will be we will be seeing more and more in the future. in lupus nephritis specifically, we recently performed a study that was based on the transcriptome of patients with active lupus nephritis. We compared these patients with patients who had active non-renal SCD, and we could see, for example, that neutrophil degranulation was the most enriched lupus nephritis specific pathway. But then we also did the gene module analysis with the premise that the genes work together in sets rather than individually. And by applying different levels of stringency, we could distill this down to three important gene modules, which were the most informative, the most discriminative, let's say, and could separate patients into three groups. And these were based on the interferon signature, which was then graded into low, intermediate, and high. And in the group of patients who had the low interferon signature, we could see that the B cell signature was low, or the B cells were down-regulated, and down-regulated were also the plasma cells and immunoglobulins gene signature. And in the intermediate interferon signature, then the B cells signature and the plasma cells immunoglobulin signature were also, all of them were upregulated, and we could see a mixed pattern in the group of patients with a high interferon signature. Now, based on this, we could perform in silico prediction of response to different therapies, so anticipated response to different therapies based on systems biology. And what we ended up with was that patients with the low interferon signature were more anticipated to respond to calcineurin inhibition, mTORC1 inhibition, or inhibition of tyrosine kinases. And then patients who had an intermediate interferon, they could benefit more from anti-CD19 therapies, anti-CD38 therapies, and we have seen now some case reports with daratumumab, for example, and also from BTK inhibition. And patients in the high interferon group were more anticipated to benefit from anti-type 1 interferon receptor therapies, such as anifrolumab, for example, anti-CD22, and again, anti-CD38. And this is just an example from lupus nephritis, and just from one experiment that we recently did. I believe that this kind of experiments help us increase our knowledge, what lies behind the clinical facets, and with time we will understand more how we, in a targeted way, can reverse dysregulation and restore health.